Thank you very much, Lina. Dear colleagues, it gives me great pleasure to present the third of a series of webinars, an educational initiative of the European Menopause and Andropause Society. The series is a true international event with prominent speakers from China, India, Russia, Brazil, with parallel translations. Thanks to a generous educational grant by Abbott, the webinars are free of charge for the participants. Today's speaker is Professor Antonina Smetnik. She's head of the Department of Gynecological Endocrinology of the National Medical Research Center for Obstetrics, Gynecology and Perinatology at the Ministry of Healthcare of the Russian Federation in Moscow. Among her other posts, Professor Smetnik is the current president of the Russian Menopause Society, of course, a prominent board member of the European Menopause and Andropause Society, a member of the Business Development Committee of the International Menopause Society Board, and a member of the editorial board of the Journal of Gynecological and Reproductive Endocrinology and Metabolism during the last 2 years. Professor Smetnik's topic is particularly interesting. It's algorithms for the use of menopausal hormone treatment. She will particularly focus on the relevance of early start. Tonya, thank you very much for being with us. The floor is yours.
Thank you so much, Professor Dimitrios Goulis. I would like to thank the participants for joining us, and I would like to thank the European Menopause and Andropause Society for this opportunity to present this webinar. I would like to start with the stages of reproductive aging, and after the reproductive stage comes the menopausal transition, and then the final menstrual period called menopause, and then post-menopause. The period of life of woman between the first and the last menstrual period is called pre-menopause, and the menopausal transition plus 1 year of postmenopause is called perimenopause. Perimenopause is one of the terms that refer to the transition from regular ovulatory menstrual cycles to irregular menstrual cycles that result from ovarian aging and the accompanying decline in oocyte quantity and quality. The clinical presentation of the late reproductive stage includes infertility, irregular menstrual cycles, menorrhagia, and a new onset of worsening of mood disorders, as well as other manifestations of the climacteric syndrome. The perimenopause symptoms are diverse. For example, the changes of menstrual pattern. Usually it starts with shorter cycles, then usually longer cycles, and sometimes irregular bleeding. Also, women usually have vasomotor symptoms like hot flashes, night sweats, sleep disturbances, psychological and cognitive problems like worsening of premenstrual syndrome, depression, irritability, mood swings, poor concentration, poor memory, vaginal dryness, decreased libido, dyspareunia, some somatic symptoms, headache, dizziness, palpitations, joint ache, and back pain, and some others like urinary incontinence, dry, itchy skin, and weight gain. Unlike postmenopause, which is characterized by low levels of estradiol and progesterone, the hallmark of perimenopause is highly variable levels of estradiol and progesterone with abrupt increases and decreases that are often described as hormonal roller coaster or hormonal chaos. What makes the management of the menopausal transition a complicated task is, in particular, the need to compensate for these major fluctuations in sex hormone levels, accounting for the reproductive aging stage the individual woman is in. Here are the stages of reproductive aging according to STRAW plus 10, and you can see that the late reproductive stage and perimenopause is characterized by a huge variability of sex hormone levels. Perimenopause starts with menstrual irregularity and lasts up to 1 year after the final menstrual period. This stage of reproductive aging arrives between a broad age range from 42 to 58 years. In the course of the study of women's health across the nation, it was identified that perimenopause starts from 4 to 8 years prior to the final menstrual period, while the median age of menopause onset across the study is 51. The immediate cause of perimenopause is the decrease in quantity and quality of oocytes, hence follicles become unresponsive to gonadotropin stimulation. Perimenopause is characterized by the depletion of follicle reserve that leads to low level of inhibin B, low levels of anti-Müllerian hormone, low ultrasound visualized antral follicle count. However, none of the aforementioned criteria is an effective diagnostic tool to determine menopause onset time. It was identified that the level of anti-Müllerian hormone is very low or even below detectable limits approximately 5 years before menopause. At the start of perimenopause, typically after 40 years of age, follicular stimulating hormone levels get somewhat elevated, thereby stimulating follicle growth, which in turn heightens the total level of estrogens. This FSH rise is caused by lower ovarian secretion of inhibin B rather than lower estradiol production. Heightened FSH levels in the luteal phase initiate follicular genesis before the corpus luteum starts to degenerate. Initiation of follicular genesis at the luteal phase leads to shortened follicular phase since the two cycles overlap rather than follow one another. This leads to early ovulation and inadequate luteal phase or absence of ovulation, as well as highly variable levels of estradiol. In perimenopausal women, estradiol secretion varies with FSH levels and may reach concentrations higher than in women under 35. While menstrual cycles are still regular in the early transition stage, progesterone levels are lower as compared to mid-reproductive age women's pattern. Testosterone levels do not change substantially during perimenopause, and a decrease in sex hormone-binding globulin production may lead to relatively high levels of bioactive estrogens and testosterone. In the early perimenopause stage, symptoms such as hot flashes generally reflect the rate of change in the level of estradiol, meaning that the levels that fall abruptly from a higher to a much lower levels provoke acute onset of vasomotor symptoms. Heavily bleeding is often triggered by an abrupt decline in the estradiol level after prolonged estradiol endometrial stimulation is discontinued and there is no progesterone effect. In the late perimenopause stage, on average 2 years prior to the final menstrual period, estradiol levels decline and FSH levels steadily rise. When a critical cutoff value is reached, oocyte count of 100 to 1000, menstrual periods stop permanently. Prevalence of abnormal uterine bleeding is around 30% among reproductive aged women and up to 70% among women in perimenopause. Hormone fluctuations and anovulation are the two most frequent causes of uterine bleeding in perimenopause. However, since this time period is characterized by relatively high estrogen levels and relatively low progesterone production, women in perimenopause are at higher risk of developing endometrial hyperplasia or carcinoma. Symptoms associated with estrogen-sensitive pathology, including endometrial polyps, uterine leiomyomas, and adenomyosis, are also more prevalent. The pathogenesis of abnormal uterine bleeding with luteal phase deficiency or anovulation are as follows. The not sufficient progesterone production or absence of its production leads to prolonged unopposed estrogenic stimulation that leads to continuous endometrium proliferation. As endometrium proliferates and doesn't get periodically shed, the endometrium growth rate becomes higher than its blood supply. This leads to irregular endometrial shedding. Bleeding becomes irregular, prolonged, or excessive. Etiology of abnormal uterine bleeding should be identified in all women, irrespective of their menopausal status, using Palm-Cohen classification. In perimenopausal women, abnormal uterine bleeding is often caused by ovulatory dysfunction, progesterone deficit, and excessive secretion of estrogens. The effect of progestogens on the endometrium are as follows. They stop estrogen-induced endometrial proliferation, stabilize endometrial vasculature and block the unconstrained vascular growth, trigger clotting cascade, produce hemostatic and antifibrinolytic action, and inhibit matrix metalloproteinases. Dydrogesterone is an ideal first-line drug since it has high selectivity for progesterone receptors and a favorable safety profile. From 11 to 60% of perimenopausal women develop vasomotor symptoms. Hot flashes begin an average of 2 years before the final menstrual period, and 85% of women will continue to experience them for more than 1 year. While there is no clear correlation, vasomotor symptoms may be triggered not only by low estradiol concentrations in late perimenopause, but also by abrupt fluctuations in its levels in early perimenopause. Progestogens alone have efficacy in treating vasomotor symptoms in early perimenopause. Dydrogesterone and bioidentical progesterone are the progestogens of choice according to the International Menopause Society guidelines. Dydrogesterone, however, has higher oral bioavailability and better safety and tolerance profiles, and is therefore better suited for long-term use. As hot flashes and other menopausal symptoms develop, dydrogesterone may be beneficial in combination with oral or transdermal estradiol, including fixed oral combined MHT regimens. So women with abnormal uterine bleeding caused by ovulatory dysfunction and/or irregular menstrual cycle with no or weak menopausal symptoms can benefit from using dydrogesterone 20 milligrams from the 11th to the 25th day of cycle. If the menopausal symptoms worsen, we can switch to the combined menopausal hormonal therapy. Usually we start with the low dose. For example, the combination of 1 milligram of estradiol and 10 milligrams of dydrogesterone sequentially. If it's not enough, we can switch to 2 milligrams of estradiol and 10 milligrams of dydrogesterone sequentially. So menopausal hormone therapy is the golden standard in treating climacteric disturbances according to the guidelines of the leading world menopause societies, International Menopause Society, North American Menopause Society, EMAS, NICE, and BMS. If we speak about the influence of menopause on the cardiovascular diseases, we need to say that vasomotor and other menopausal symptoms are generally associated with an increased risk of cardiovascular disease in postmenopausal women. Women with climacteric symptoms are at 34% higher risk of coronary heart disease, are at 30% higher risk of stroke, and at 48% higher risk of other cardiovascular diseases. Vasomotor symptoms are the early signs of covert risk of cardiovascular events, stroke, myocardial infarction, osteoporotic fractures, and cognitive decline. According to the MESA trial, analysis of 12 years of follow-up on MHT use in postmenopausal women, Each year of delaying of menopausal hormone therapy initiation had a significant correlation with coronary artery calcification, irrespective of whether or not calcium buildup had been identified at baseline. According to the ELITE trial, oral estradiol treatment was found to be associated with reduced progression of subclinical atherosclerosis when initiated within 6 years after the menopause. When initiated more than 10 years of postmenopause, the therapy didn't have any effect on slowing atherosclerosis progression. Also, it is the early start of menopausal hormone therapy that reduced all-cause mortality by 30% if was started before 10 years of postmenopause, there was shown decreased the all-cause mortality and coronary heart disease as compared to placebo or absent treatment. Timely MHT start before 50 years is an important longevity factor, and according to the prospective study, Netherlands cohort study, the MHT start at the age before 50 increases the possibility of reaching the age of 90 and older. According to the new publication in the Lancet Diabetes and Endocrinology Journal, the American Heart Association scientific statement, menopause transition is a golden age to prevent cardiovascular disease. Ischemic heart disease and stroke are the world's leading causes of death in both men and women, according to the WHO's Global Health Estimates in 2019. Menopausal transition is a time of accelerating of cardiovascular disease risk. Endocrine and metabolic modifications are tightly linked during the menopausal transition. Women are more vulnerable than men in terms of cardiovascular risk induced by high blood pressure, which is very common after the age of 50. Menopausal hormone therapy initiated in women younger than 60 or within 10 years of post-menopause to alleviate menopause symptoms and to prevent or treat osteoporosis is currently the sole intervention that decreases the risk of cardiovascular disease and diabetes in healthy women at midlife. Menopause also has an impact on type 2 diabetes mellitus. And as demonstrated by meta-analysis with diabetes, increases the risk of developing breast cancer by 23%. And with diabetes, the onset of menopause itself is earlier, about 2.5 years. And according to the WHI study, the menopausal hormone therapy, combined menopausal hormone therapy, lowers the risk of type 2 diabetes mellitus by 21%, whereas the monotherapy of the estrogen monotherapy lowers the risk by 12%. It is the oral menopausal hormone therapy that improves glucose and lipid metabolism and leads to less central obesity, less abdominal adiposity, increase in energy expenditure, improved insulin sensitivity, and improved lipid profile. Also, it was shown that menopausal hormone therapy with estradiol and dydrogesterone may prevent development of insulin resistance and type 2 diabetes mellitus. Women on MHT experience significant reduction in abdominal fat accumulation, and according to the meta-analysis that included 11 studies with cumulative sample of about 2,500 of premenopausal and then postmenopausal women, MHT has a potential of preventing central obesity in postmenopausal women. According to EMAS guidelines in 2018, menopausal hormone therapy has a favorable effect on glucose homeostasis, both in women with and in women without diabetes. Timely starts of MHT may delay development of type 2 diabetes, and oral MHT administration is preferable except for absolute contraindications. Among available and well-studied progestogens used as a part of oral MHT, progesterone and dydrogesterone are the progestogens of choice. Speaking about menopause and osteoporosis, we should say that loss of bone mineral density begins several years prior to menopause, and loss of bone mineral density is at its greatest during the first 3 to 5 years of postmenopause. Initiation of menopausal hormone therapy at the onset of menopausal symptoms demonstrates a high fracture protective effect. Here is the data from a case control study by Cheng and others, timing and dosage of and adherence to hormone replacement therapy and fracture risk in women with menopausal syndrome. And this study included more than 26 women aged over 45. Current and past use of estrogen and progestogen therapy protects against bone fracture. The protective effect is dose-dependent, increases with cumulative daily dose and adherence, and initiation of MHT at the onset of menopausal symptoms demonstrates a higher fracture protective effect. Joint pain is the most common symptom of climacteric syndrome in 21% of women. Joint pain and stiffness was observed in 41% of women in perimenopause as compared to 25% of women in premenopause. According to the Women's Health Initiative study, women on combined menopausal hormone therapy showed a significant reduction in joint pain and stiffness as compared to the control group. Women on MHT had lower frequency of muscle skeletal symptoms such as joint pain and stiffness, general pain, and back and neck pain. There is increasing evidence that estrogens play a role in maintaining the homeostasis of articular tissues and hence of the joint itself. Prevalence and incidence of osteoarthritis in 50+ age group is higher in women than in men. WHI had demonstrated that 44% of postmenopausal women are afflicted by osteoarthritis, and this number increases with age progression and BMI increase. Loss of cartilage volume and in the knee joint is higher in women than in men. The difference becomes significant after the age of 50. Sexual dysfunction, of course, is associated with a lower quality of life and is characterized by constant issues with sexual response and/or satisfaction. Sexual dysfunction in women manifests as pain, vaginal dryness, satisfaction disorder, orgasmic disorder, arousal disorder, and decreased libido. Sexual dysfunction affects almost every postmenopausal woman. Up to 63% of women experience sexual dysfunction in perimenopause, and up to 98.5% increase in prevalence of sexual dysfunction is seen in postmenopausal women. Women's sexual health is affected in the course of menopause transition as a result of decrease in estradiol level, and the effect is further exacerbated in postmenopause. It was shown that therapy with 2 milligrams of estradiol with 10 milligrams of dydrogesterone sequentially has a positive effect on sexual function in perimenopause. And here we can see the decrease in frequency of sexual dysfunction, decreased libido, arousal disorder, vaginal dryness, satisfaction disorder, pain, and orgasmic disorder. Gradual loss of ovarian function is one of the factors contributing to the development of sexual dysfunction in women. There is a clear relationship between the worsening sexual function and the STRO+10 reproductive aging stage the woman is in. Use of combined estradiol and dydrogesterone menopausal hormone therapy in perimenopausal women has a positive effect on sexual function. Decrease in estradiol level is associated with multiple changes, also in the brain, including cognitive decline. Cognitive symptoms are associated with depression. The incidence of depression is often also higher in perimenopause. Observational studies indicate an increased risk of memory deficits and Alzheimer's disease associated with premature surgical menopause. 75% of women in menopausal transition experience memory deficit. Observational data suggests that younger age or fewer years since menopause may be associated with positive effects of MHT, whereas commencement of MHT in later years is associated with an increased risk of dementia. Functional MRI data suggests that there is improved efficiency of brain function during a sustained attention task in postmenopausal women receiving estradiol treatment. Surgical premature or early menopause increases the risk of Alzheimer's disease by 70%. If menopausal hormone therapy commences before the age of 50, the risk is removed. Menopausal hormone therapy may correct the memory deficit directly, but the improved cognition may be due to improvement in other symptoms that are synergistic in exacerbating the memory loss, such as sleep deprivation and hot flashes. Estrogen deprivation also is one of the main reasons for skin aging. For example, wrinkle formation, slackness and decrease in elasticity, dryness and tightness, skin peeling, change in color and tone, vascularity spots and spider nevi around wings of the nose, chin and cheeks, body hair overgrowth. It is known that MHT has a positive effect on the skin and may prevent collagen loss, may improve water retention capacity, and increases skin thickness. According to one study, the 3 months of therapy with 1 milligram of estradiol and 10 milligrams of dydrogesterone sequentially in perimenopause and 1 milligram of estradiol and 5 milligrams of dydrogesterone continuously in postmenopause showed that some skin aging symptoms were reversal. For example, dryness, peeling, poor skin turgor, wrinkles, dull tone, spider nevi, and excessive hair growth. So the timely start of menopausal hormone therapy is pivotal in maintaining female health in peri and post-menopause. In our country, in Russia, we have some combinations of estradiol and dydrogesterone available. As cyclical MHT regimens, we have low dosage, 1 milligram of estradiol with 10 milligrams of dydrogesterone sequentially. Standard estradiol dosage, 2 milligrams of estradiol and 10 milligrams of dydrogesterone sequentially. Also, we have continuous MHT regimens, low dose, 1 milligram of estradiol with 5 milligrams of dydrogesterone, and ultra low dosage 0.5 milligrams of estradiol and 2.5 milligrams of dydrogesterone. And in March 2021, we published the algorithms for menopausal hormonal therapy in peri and postmenopausal women. It was a joint position statement of Russian Society of Obstetrics and Gynecologists, Russian Menopause Society, Society of Gynecological Endocrinologists, and Russian Society of Osteoporosis, and it reflects the position of all the relevant societies in Russia and provides step-by-step practice pattern in dose selection, bleeding management in menopausal hormone therapy, and switching from combined oral contraceptives to MHT and switching between different dosage, and presents the modern conception of early start of menopausal hormone therapy. So there is convincing evidence that comprehensive benefits in women starting menopausal hormone therapy in a timely manner. To evaluate the woman's window of opportunity for starting MHT, two key factors are to be taken into account: age and the time after menopause. Women aged under 60 and or less than 10 years of postmenopause are considered optimal candidates for menopausal hormone therapy onset. Early onset of menopausal hormone therapy may be an option in 45+ women who are amenorrheic but present with vasomotor symptoms. Women under 45 years of age presenting with oligo or amenorrhea with or without vasomotor symptoms should undergo a set of hormonal tests: follicular stimulating hormone level twice with 4 to 6 weeks between the tests, thyrotropin and prolactin. Menopausal hormone therapy may be considered at FSH level more than 25. Doctors need to address the following clinical issues as they stratify treatment tactics for the patient's stage of reproductive aging. The choice of starting regimen and dosage should depend on the patient's stage of reproductive aging, STRO +10, age, hysterectomy or intact uterus, and risk assessments for cardiovascular and oncological disorders and postmenopausal osteoporosis. A possibility to correct the dosage, if necessary, should remain open. A possibility to change the regimen should remain open, consistent with the patient's age and needs. These algorithms apply to the most prevalent clinical cases and do not necessarily cover all possible multi-morbid conditions. Women with intact uterus should receive combined hormonal therapy with a progestogenic as well as estrogenic component. The progestogen required to protect the endometrium from the estrogenic proliferative effects, thus preventing the risk of endometrial hyperplasia. Women after hysterectomy should get continuous estrogen-only therapy, except for women who have undergone surgery for endometriosis, in which case the preferred choice is combined estrogen, progestogen, MHT, or Tibolol. And some women in perimenopause use combined oral contraceptives. And of course, these drugs have contraceptive effects, unlike menopausal hormonal therapy. However, they can only mask the menopausal symptoms, such as vasomotor symptoms, sleep quality, and mood. And they have no beneficial effects in preventing cardiovascular events, osteoporosis or sarcopenia, dementia, insulin resistance, or type 2 diabetes mellitus. And here only menopausal hormone therapy can have beneficial and preventive effects. When can we decide to switch from combined oral contraceptive to menopausal hormone therapy in perimenopause? Here are the indications for switching, and at least one of the following should be present. For example, menopausal symptoms that women have after combined oral contraceptive discontinuation, or menopausal symptoms or genitourinary syndrome of menopause during oral contraceptive use, including during hormone-free periods. Or women uses oral contraceptive off-label for menopausal symptoms in any age, or other MHT indications such as osteoporosis prevention, for example, when we use FRAX tool to assess the fracture risk, and disappearance of withdrawal bleeding during oral contraceptive use, or per patient request, we can measure FSH levels twice during the hormone-free period, and if it's elevated or over 30, we can decide to switch from oral contraceptives to MHT. And then we suggest that there is no need to have a gap between oral contraceptives and MHT because women can suffer from vasomotor symptoms. We suggest that she starts taking MHT just in that time when she would start her next oral contraceptive package. And if she is at the age of 55 or more, we suggest continuous MHT in low or ultra low dose. In our country, it's Femastone Conti or Femastone Mini. And if she is in age before 45, she can start with cyclical MHT in standard or high dose, for example, Femastone 2. And if she is in the age between 45 and 55 years, she can start with cyclical MHT in low dose, for example, Femastone 1. The patient needs to be educated that MHT medicines do not provide contraception, and therefore other methods of contraception, such as barrier, are to be used if the need arises. In about 2 to 3 months after switching to MHT, the patient should undergo an assessment for efficacy, possible side effects, discharge, if any, and pelvic ultrasound should be considered if needed. If the user of a cyclical MHT regimen expects menstrual-like episodes but remains totally or nearly amenorrheic, and pregnancy or other causes of amenorrhea can be excluded, switching to continuous MHT regimen may be considered. The overall recommendation for perimenopausal women is to start with cyclical low dosage regimen, for example, 1 milligram of estradiol with 10 milligrams of dydrogesterone sequentially. The response should be assessed on an individual basis in 1 to 3 months, with possible increase of the dosage of estradiol, switching to the 2 milligrams of estradiol if the symptoms persist. In patients with early menopause at age from 40 to 44, or in patients with premature ovarian insufficiency under the age of 40, menopausal hormone therapy should be started with the standard cyclical regimen of the oral 2 milligrams of estradiol with 10 milligrams of dydrogesterone drug. If the symptoms aren't alleviated, as assessed 1 to 2 months after the start of MHT, a high dosage cyclical regimen of 4 milligrams of estradiol with 20 milligrams of dydrogesterone per day may be considered. The following cyclical combined menopausal hormone therapy users may need switching to continuous combined MHT. For example, women who started MHT after the age of 50, after using low dosage cyclical MHT for 1 to 2 years, or women who started MHT before the age of 50, as the women progresses to the average age of menopause, 51 to 52 years. Women who experience changes in their menstrual-like bleeding as 2 consecutive cycles produce either minor spotting or no bleeding, and women who wish to end menstrual-like episodes after using low dosage cyclical MHT, for example, 1 milligram of estradiol with 10 milligrams of dydrogesterone sequentially for at least 12 months to prevent breakthrough bleeding. If we start MHT in postmenopausal women, we usually start with the low dosage MHT, 1 milligrams of estradiol with 5 milligrams of dydrogesterone, Femastone Conti. and assess the clinical efficacy. And if women takes this dosage for 3 to 5 years, we can switch to ultra-low dosage of MHT, 0.5 milligrams of estradiol with 2.5 milligrams of dydrogesterone, Fimaston Mini. And then assess the efficacy. And if the efficacy is assessed as insufficient in 1 or 2 months, we can return to low dosage MHT. Postmenopausal women also may start using MHT with the ultra-low dose. However, you should bear in mind that ultra-low dose MHT is not approved for the prevention of osteoporosis. Another important consideration should be that in women aged under 55 and less than 5 years of postmenopause and having BMI more than 30, ultra-low dose MHT may be not sufficient. So menopausal hormone therapy is the only intervention that helps to reduce the risk of cardiovascular disease and diabetes in healthy mid-aged women as they experience menopause-associated estrogen deficit. Menopausal hormone therapy may have a preventive effect for a range of age-associated chronic diseases, including osteoporosis. Of importance for effective osteoporosis prophylaxis are compliance, adequate dose regimen, and duration of MHT use. Women receiving MHT had lower incidence of musculoskeletal symptoms, such as joint pains and stiffness, general pain, back and neck pain. MHT may prevent high rate of collagen loss during the first 5 years of postmenopause. MHT improves water retention capacity and skin thickness. Observational studies indicate positive effect of using MHT for cognitive deficits in younger aged women or those with fewer years since menopause, whereas commencement of menopausal hormone therapy in later years is associated with an increased risk of dementia. Timely initiation of menopausal hormone therapy at the onset of menopausal symptoms provides for greater protective effect and substantial increase in the quality of life. Oral contraceptives are not as protective as menopausal hormone therapy and should be therefore viewed as an alternative treatment for women with menopausal symptoms. Leading global scientific societies recognize estradiol and dydrogesterone combined menopausal hormone therapy as the optimal treatment for menopausal symptoms, evidenced by many international studies. In the age group younger than 60 years or within 10 years after postmenopause, after the menopause, the benefits of menopausal hormone therapy are most likely to outweigh any risk and can be considered as first-line therapy. And there is no mandatory time limit for duration of menopausal hormone therapy, provided that it is consistent with the treatment goals. And here you can use this QR code to download the algorithms for menopausal hormonal therapy and peri and postmenopausal women, our joint position statement. It is the English version. We invite you to download this paper. And also I invite our participants to join the Russian Menopause Society, and you can become a member of the Russian Menopause Society absolutely for free. And you just need to sign up on our website, menopause-russia.org. I thank you so much for your attention, and I'm ready to answer your questions.
Thank you, Dr. Smetnik, for such a wonderful presentation. Now we will begin the Q&A session. I remind all the attendees that they can still submit their questions using the Q&A widget located in their control panel. Professor Goulis, the floor is yours.
Thank you, Antonina. We have learned a lot with your lecture. It was a very nice and very clear overview in the field of menopausal hormone therapy. So I can see that we have many questions for the 15 minutes that we have available. I may ask with a question from Ivana asking, when would you recommend to healthy women to switch from oral contraceptive to HRT? I think, Tonya, that you have already mentioned how to do it, but would you like to add a little bit on this? How we switch from oral contraceptive to HRT?
Mm-hmm. Thank you, Professor Goulis. First of all, we need to determine that it is the right time to switch from the oral contraceptive pills to the menopausal hormone therapy. We should understand that these women have some menopausal or genital urinary symptoms, either per the oral contraception discontinuation or during the usage of oral contraceptives, or this woman has some has postmenopausal osteoporosis, so needs to prevent fracture and postmenopausal osteoporosis, or if this woman has found out that her withdrawal bleeding on oral contraceptive stopped, then we can measure the FSH level, and if you see the elevated FSH level, we can understand that maybe it is the right time to switch to the menopausal hormone therapy. Of course, we need to inform this woman that menopausal hormone therapy has no contraceptive effect, and she needs to use other ways of contraception. And we suggest that there is no need to make a big gap between the package of oral contraceptives and menopausal hormone therapy, because women can suffer from menopausal symptoms during this period. And so we suggest that the woman should start menopausal hormone therapy just in that day that she would start the new package of oral contraceptives. And then we should understand, depending on the age of women, if she is after 55, we can just move and switch to the combined menopausal hormone therapy continuously. If she is before 45, we move to the standard dose of estradiol, for example, Femastone 2. It's in sequentially, and if she is between 45 and 55 years of age, we switch to the low dose sequential hormone therapy, for example, Femastone 1.
Thank you very much, Tonya. To conclude this topic, it's Trang that asks, could we, if we want, could we continue to use oral contraceptive as hormone replacement therapy in menopausal women? And together with this, Fotini is asking, hi Fotini, that it's not clear why women already on oral contraceptive may have menopausal symptoms. Is this a possibility that despite being on oral contraceptive, still to continue to have some menopausal symptoms?
Well, I think that, I see these women and I understand that some women have menopausal symptoms despite of the combined oral contraceptive use. And this is the sign for us that it is the right time to switch to the menopausal hormone therapy upon indications. Yes, menopausal symptoms. It's an indication for menopausal hormone therapy, not for the combined oral contraceptive.
I see. Very nice. I have a couple of questions about transdermal HRT. For example, would you consider transdermal estrogen to be superior to oral estrogen in view of the better safety profile regarding risk of stroke, for example?
I think that all types of hormonal therapy that we have nowadays are quite safe because we have a lot of studies on its safety. And I should mention this that in July 2021, there was an interesting publication when the transdermal and oral estrogens were compared in terms of risk of venous thromboembolism, and it was shown that there is not so that there is no statistically significant difference between the route of administration of estrogens, either oral or transdermal. It's very interesting data, and I think that we need to keep it in mind. And really, if we look in the instruction in the contraindications for either transdermal or oral estrogens, the contraindications are very similar. And if a woman had a thrombosis, it is a contraindication as for oral estrogens and for transdermal estrogens as well.
Thank you, Tony. It's very nice always to try to apply evidence-based medicine and try to answer questions according to the evidence. We all have in mind the pathophysiology, the first pass effect from the liver, but it's the data actually that you have to see if the oral HRT increases coagulation or not. So we need data about this. We have a couple of questions from Peru. It seems that we are very popular in Peru. It's about the famous window of opportunity that you mentioned. And Martha asks, is there any beneficial effect if the hormonal supplementation begin after the 60th year of age?
Well, if such happens, we can expect some beneficial effect on vasomotor symptoms and some beneficial effect on osteoporosis, but this beneficial effect on osteoporosis will be less than in those women who begin menopausal hormone therapy before the age of 60. However, we can have some adverse effects because there is this window of opportunity tells us that if a woman starts HRT after MHT after 10 years of postmenopause or after 60 years of age, there is an altered biology of estradiol, and we can have some negative rather than beneficial effects on cardiovascular system and also on some cognitive function. Yes, and of course, women can benefit mostly if she started the menopausal hormone therapy timely before the age of 60 or before the 10 years of postmenopause.
Thank you very much, Tonia, for this clear answer. We have a couple of questions about uterine fibroids. What can we say about MHT in a woman that has uterine fibroids?
Mm-hmm. If a woman has small uterine fibroids, not more than 3 centimeters and not more than 3 fibroids, and if they are not submucous localization, then we can consider using MHT if she has indications for MHT.
Mm-hmm. Another question from Russia. Would you transfer a woman that is currently on ultra low dose to a low dose because the first dose has not evidence that prevent osteoporosis, actually? So would you increase her from ultra low to low dose because of prevention of osteoporosis?
Well, we need to have an individual approach, and we need to take into account the age of this woman and the bone mineral density of this woman. And if we understand that she's in early post-menopause and that she has a risk of osteoporosis or fractures, then we can decide and switch to the low dosage MHT from the ultra low dosage.
Mm-hmm. Mm-hmm. Very nice. Another question from Russia. If we can combine percutaneous estrogen and progestogen, I assume by mouth actually. So can we make combinations like this? Percutaneous estrogen and progesterone by mouth.
Oh, yes, of course. We can combine percutaneous estrogens and oral progestogens like dydrogesterone because it has a good bioavailability. When it's used by oral route, we can easily it combined either in continuous or sequential regimen.
I see. Another question by Ivana. Would you recommend the intrauterine device with levonorgestrel in women over 55 years who are on estrogen therapy, or it would be better to switch to tibolone? So she wants to know about a woman 55 years old. She is on MHT, and can she continue with levonorgestrel in the intrauterine device, or it would be better to switch to tibolone?
It depends. If the woman is already has already the intrauterine device, levonorgestrel intrauterine device, for example, for 2 years, and she was perimenopausal, and now she stopped her bleeding, we can just continue with the intrauterine device, not more for 3 more years, because it can be placed into uterus only for 5 years, and add some, for example, percutaneous or oral estrogen. But if we are talking about the first usage of MHT at the age of 55, I think there is no need to start with the intrauterine levonorgestrel device. It is easy to use other options, either tibolone or combination of estradiol with dydrogesterone or micronized progesterone in a continuous regimen.
Thank you very much. I have to cordially thank Professor Smetnik for this excellent discussion. We have many questions, Tonya, and I'm sure that you'd be happy to transfer them to you and try to answer them through emails, actually. We are discussing for 15 minutes now. We try to answer as many as possible, but there are some more from Russia, from Peru, from South America, from Australia, all over the world. So this concludes our webinar. The 4th webinar will take place on 24th of November and will deal with the role of progestogens in menopausal hormonal therapy. So we are going to focus, to concentrate on the progestogen, the role of progestogens in menopausal hormone therapy. Today, we have an excellent introduction to this topic by Professor Smetnik. Our speaker in November would be Professor Luciano Pompei from Brazil, and the EMAS moderator would be Professor Tommaso Simoncini from Italy. So having said this, thank you very much, all your 400 of you, for your active participation. Most of all, our expert today, Professor Antonina Smetnik from Moscow, and the European Menopause and Andropause Society is waiting for your active participation in this educational initiative. Thank you very much.
Thank you so much, Professor Goulis. Thank you to all the participants. Thank you so much for this pleasure. Thank you. Bye.
All right, and with this, we conclude today's event. Thank you so much, Dr. Smetnik and Professor Goulis, for an amazing session. And thank you to all the attendees for being here today. Have a great rest of the day.